Patient Safety and Quality Clinical Excellence Queensland has developed a podcast series for Queensland Health staff and Hospital and Health Board members to hear from guest speakers on topics relevant to safety and quality in short bite-sized segments. All episodes are recorded on the lands of the Yagara and Turrbal people. We respectfully acknowledge them as the traditional custodians of Meanjin and pay respects to the elders past, present and emerging.
Welcome to part 2 of the Clinical Incident Management podcast episode. I'm Denis Morton. In the previous episode, we covered a foundational overview of clinical incident management and how that applies in the context of Queensland Health with our guest, Dr. Lynnette Knowles. In this episode, Lynnette's back and we'll be having more of a focus on the key roles and functions of the Hospital and Health Board. So Lynnette, to kick us off, can you explain what is important for board members in the role of clinical incident management and why?
Board members are super important, can I say, Denis? Board members who bring an understanding of quality and safety have a very positive role in building a culture and influencing safety across the organisation. So having engaged, skilled leadership is paramount to improving the way we do things within healthcare. So a good understanding of safety and quality enables board members to really ask targeted questions, to understand and be assured that things are working well within their organisation, but also to help them with risk management and ensuring compliance to their organisation as well. And finally, having this skill and knowledge set also enables them to work well with the executive to set the hospital and health service strategy and culture. And I think with this approach, it's really preventative and it helps stem clinical incidents and organisational safety issues before they can occur.
Great points. So for the hospital and health boards, in regards to clinical incident management, what should be included for board members to look at?
So most boards will have a established safety and quality committee for the board, a board safety and quality committee. And this committee will receive certain packs of information. And really from a clinical incident management perspective, what they should be anticipating to see is information around Severity Assessment Code 1s, their SAC 1s, and understanding where the location of these SAC 1s have occurred and also the type. So this may be the department or the level of harm or also the type of harm that's being experienced within the organisation. It gives a really clear indication of process as well through the organisation. So one reporting will help the board to understand how many are currently in review and also how many have been completed and how many recommendations are outstanding. So committees should be considering factors when they're looking at this information, particularly around those number of incidents, but also around any trends which they can see coming up through SIM and the SAC 1 reports which are coming through.
All right, I'm going to ask you a controversial question, Lynnette, about the number of incidents. Is a high number of incidents bad? Should we be having targets for incident numbers?
I'm going to hedge my bets here, Denis. I'm going to say, look, high numbers of incidents often alarm people. I think that in my experience, when you have a high reporting culture or a culture which is safety focused, you can anticipate to see reports. What you're looking for is the quality within those reports and ensuring that they are really reflective of good reporting within the system. I think when you do see high reports, it is a good trigger to start asking questions and really understand what exactly is happening, whether it is actually a reporting culture or whether we actually do have some issues here. So I think either way, it's a trigger to ask good, curious questions and sort of lean forward as both a board and an executive.
Yep, great. So we might see trends over time and we might see a jump in incidents that are being reported, but maybe that's because people feel safer to speak up or really understand the importance of clinical incident reporting. Yes. Or it could be because there's been more harm that's been occurring, but it's important to look into it a bit further.
Correct. And I think both give us great information about next actions that are needed.
All right. I'm going to ask you about a different type of incident now. Sentinel events. Can you explain what sentinel events are?
Yes. So sentinel events are a list of events which have been provided by the Australian Commission on Safety and Quality in Healthcare. And these type are very serious incidents which have occurred which are wholly preventable and have caused serious harm or death to a patient. The really important point here is wholly preventable, and so we have in the past called them never events. So these are ones that definitely trigger in the system that we have work to do and that there are definitely safety issues. The Productivity Commission provides an annual report on government services, and we will see annually a published report on sentinel services that have happened across jurisdictions, states, across Australia, and it gives a really good indication of what's occurring within our health system and how we're performing there.
Okay. And I know some examples would be where surgery has been performed on the wrong patient, or someone's been operated on their left arm when they came in for their right arm, things like that shouldn't happen.
That's right.
And there's a full list available online as well.
Yes, absolutely.
Thank you. Now, what else should hospital and health boards be looking at?
So when we're talking about clinical incident management, I had mentioned recommendations. So when the information is being provided, as I said, the information should provide full guidance of where organisations currently sit within the review and remediation phase within the incident management. So I would say first and foremost, hospital and health boards should be looking at overdue recommendations, particularly what has been actioned but where things are stalling, because that is a great trigger point to really question whether or not those recommendations are fit for purpose, or whether or not they need more resourcing, or even indeed if they need to be stopped and reconsidered. So that's important. The second is trends across clinical incidents. Now this might be the categorisation of incidents which are trending. It may be the type of incident. It may be falls. It could also be medication incidents or other incidents which could be leading towards the clinical incident categories. I think the third is culture surveys. So complaint trends and patient experience surveys are really important there. That gives a great flavour to the board about what is occurring within the organisation from a patient, consumer, community perspective. But equally, culture surveys from staff are really critical around patient safety and gives a great flavour of the feeling of trust and support within the organisation, engagement, but also feelings of confidence in ability to speak up. So it's really important that when safety and quality, board safety and quality committees are looking at this information, that they're looking in totality to the information that is being provided. So as you mentioned earlier, with the numbers of reports which are going through, if we were to just take that data piece on its own, it may tell us a very different story to an increase in reports and a culture of safety which is evolving and positive responses which are coming back from patients. So you can see that as we look in totality across our reports, it really does give us a different flavour as to what's happening. So one of the big things I'd highlight is that one of the most useful things a Safety and Quality Committee can do is look in totality across all the different types of reports that they're seeing. I should also include performance reporting as being a really important piece, as well as HR reporting, because that will tell you whether or not you have the right staff in the right place. It'll tell you how quickly you're moving through staff and how trained they are, but it'll also tell you how many patients are coming through your system and the pressures which are happening in your system. And adding that to your safety and quality suite really empowers you and gives you a very different view of what's happening through the organisation.
Yeah, good points. You mentioned culture when you were talking about that, and that's something that's really important for patient safety. And we get to hear the terms safety 1 and safety 2 referred to a lot, and it's probably not well understood by many. Can you just briefly explain safety 1 and safety 2 principles?
Yeah, and I will point out, as you've said, they're principles, and the way we apply and think through, I think they're helpful in the conversation, having the right language to talk through safety and quality. Historically, when we've talked about safety 1, it really is about placing our focus point on clinical incidents as they've occurred, and really identifying the causes of adverse events. And that's about, it's a reactive response to what's going on. It is important because it, again, gives us good feedback and information about our system, but really the horse is bolted. When we're looking at safety 2, it's aiming to understand how safety occurs within our system, what impacts the system and improves safety, and in essence, what actually goes right. When we think about the huge number of admissions and presentations we have to our hospital, there is a lot that happens and goes right throughout our organisation. And one of our greatest strengths is actually our people and the way that they respond in such a complex environment. Safety too is an approach that helps us to understand how we harness that that to improve the future. That being said, with all the amazing things that Safety 2 brings, we can't let go of Safety 1. Safety 1 is important, and it really does enable a deep understanding of the incidents as they happen, and that is important for everyone involved. So I think when we're thinking through both Safety 1 and Safety 2, when we look at these two principles together, it really does bring into relief our understanding of how work actually happens. And when we think through work as imagined, which is the way we think things are done through policies and procedures and through regulations and the such, it's very much contrasted with the work as done. So when we have a really busy day with lots of presentations and the way that things are done are stretched because we're trying to respond to needs at the time, there is that tension within our system. And it's important that as we work through safety, we take that dichotomy in mind, and that, particularly when we're making recommendations, that we build upon our strengths within the system as well.
That's great. And I would imagine when leaders take the time to get to know why clinicians are doing workarounds for that work is done versus work is imagined, taking the time to get to understand why and what's important for the clinicians as well would have a really positive impact on the culture.
Oh, for sure. Who knows the work better than the clinicians, the people who are providing care every day? And I would equally say our patients and consumers also can really inform that work as done every day and what is working. And it's a really rich opportunity for us to look at our systems and re-engineer and design them for people going into the future as well.
Yeah. The other term that we hear a bit is restorative just culture. Can you explain that one to me, Lynnette?
Yes. So I think taking us back, Denis, in the past, really safety and quality has had a feel around it from a blame culture perspective, and that is that when things go wrong, someone is responsible. As we've understood safety and quality further, we understand that actually it's a really complicated system. It's a complex system, and I'd probably even use the term ecosystem. And that means that there are systems which work around people which can greatly impact whether or not care is safe or otherwise. And so with that change of knowledge, restorative just culture is great language to help us describe how we now think about safety and quality, and we think about the humans who provide care within our systems. When we think about restorative just culture, we're thinking about whether or not we're moving through into understanding what's happened through a learning lens. There are 3 questions that just culture requires us to think through. The first is who has been hurt. And often we've talked about patients and consumers and families as being those who have been hurt, and there is definitely harm there. But there's also harm with the people who provide care as well. They also are hurt, and they also have harm that has been caused there. The second question is, what are their needs? And that often is a very important question to delve into. Sometimes it's very clear and sometimes it's not. And I think when we look at our clinical incidents, it's a great opportunity for us to look at the analysis and understand what needs need to be met. The needs for patients are often ongoing care, support, and an ongoing relationship with the patients and the families to enhance trust within the organisation, but equally the same could be said for our clinicians. I would also add too, they have the need to understand that what's happened so that they can also change their practice and change their approach to how they provide care. And the third question we need to think about is how we meet those needs. So how do we as leaders, as executive, as board, as an organisation come together to meet those needs and provide a safe culture for all who are involved in healthcare. So it's quite a big approach, but absolutely central to safety and quality and cultures within healthcare.
Yeah, and I think that's a really nice point to finish on, Lynnette, because everyone has an impact on the culture of the organisation, and it can't be emphasised enough how much of an impact the boards have on the culture within an organisation as well, particularly when it comes to patient safety. So thank you very much, Lynnette. It's been really wonderful talking to you about clinical incident management. We've covered a lot, I think, and I just wanted to thank you very much for your time.
Thanks so much, Des. It's been an absolute privilege, and I've really enjoyed our conversation.
Great. Now that draws a close on this episode. Further information regarding clinical incident management, including the best practice guide, can be found online at both the Queensland Health public-facing website and QEPS. Thanks for listening.